near the Asda and the railway station in Bournemouth. And it's home to the Faculty of Health and Social Sciences within the university. So you'll see that we have a number of different departments within the Faculty of Health and Social Sciences, and Stevie and I are based within Social Sciences and Social Work. And we'll just move on to the next slide for me to tell you a bit about the departments that we're part of. So within the departments of Social Sciences and Social Work, I'm academic lead for the PEER partnership, which is public involvement in education and research. So we're really interested in making sure that our local communities, people that are affected most by health and social care research, have a part to play in the research that we do, and their voices are heard. That fits also with the research centre that we're part of, which is the Research Centre for Seldom Heard Voices. And collectively, what we're interested in is research that's really responding to real world challenges that actually make a difference. So we're looking all the time with our researchers, bringing researchers together with local organisations and services and local communities to look at what we should be researching, how we should be researching it, and improving outcome for our local communities. In particular, we're interested in engaging with quite marginalised communities, so people that often aren't heard, but are often the most affected by a particular research topic. And that's what brings us to today's workshop, because we've been doing some research within the university and within the research centre around digital exclusion. So this idea that actually when everything went online, when COVID first hit, that actually that created some solutions for some people in being able to access health and social and community care online or by phone. But for other people, actually it created a huge number of problems that we still need to explore, and we want to explore together to look at how we manage that and how we kind of identify solutions to that. Next slide, please, Stevie. So Stevie and I were approached, because of our work with the Research Centre for Seldom Heard Voices, to do some work with National Voices. So I don't know if everyone's familiar with National Voices, but they're, as it says here, they're a coalition of a lot of charities and community organisations that work in health and social care, 180, in fact, 180 different organisations and charities. And collectively, they kind of have a voice to identify what current issues are and explore and identify solutions. So very quickly at the start of the pandemic, they were contacted by a lot of their member organisations concerned about digital exclusion. And they set about doing a piece of work that not only identified what the issues were, but brought together all the best practice, things that were working, and sharing that right across the networks. And if we can just move on to the next slide, Stevie. We were involved in this report that they produced, which is called Unlocking the Digital Front Door, and we'll share a link with it to you. We have got some hard copies as well, if anyone would like us to post it out to you. What's brilliant about National Voices in this report is, as I said, they don't just identify the issues, they identify solutions. And so this report is full of case studies and examples of things that work and things that have helped. Stevie and I were involved in developing some personal narratives to illustrate some of the themes and issues that were identified in the bigger report from the literature review, and to inform some of the patient-facing information and work that's happening as a result. And that's in the purple report there. So some fairly detailed case studies from people that felt digitally excluded to try and illustrate actually some of the quite complex and nuanced reasons as to why that might be. Next slide, please, Stephen. So we've got a fairly packed agenda for today. The first half is a number of different people speaking and sharing some of the insights of what this means for us locally. We would like you to interact all the way through those presentations by writing comments in the chat. So we'll need you to keep your microphones muted, but please do write questions, but also just comments, observations, things that resonate for you or mean something for you within the chat. I'm very pleased to say that we've got Dr. Tanya Steed with us, who's Clinical Director of the Weymouth and Portland Primary Care Network, and she's going to speak in a minute about the impact of digital exclusion on health inequalities in Weymouth and Portland. Stevie and I will then share a little bit about the Unlocking the Digital Front Door work that we did with National Voices, some of the themes that emerged from that work, and Stevie will talk specifically about some of the people that she interviewed for those case studies and some of the quotes from those people, so we can make sure that we're really amplifying those voices so we can gain insight from their experiences. And then Peter Greensmith, who's the chair of the Weymouth and Portland Patient Participation Group, a member of the PCN Partnership Board, is going to talk about some work that they have been doing to really look at what the local situation is in Weymouth and Portland in terms of who has access to the internet, who's able to access health and social care by phone, and really kind of identify what some of the challenges are that we need to address within our kind of collective but local practice. We will kind of factor in a break, but then the bulk of the kind of afternoon is going to be us all working in small groups and really quite focused groups. So we've got some tasks and some challenges set for you to do in those working groups. So there'll be lots of opportunity to discuss issues, to highlight what it means for you, but really what we want to do is kind of capture some of the what, the so what and the now what in terms of what it means for your practice or your everyday life, and some solutions to that we can all kind of support each other to work on. Okay, next slide please, Stevie. So I'm going to hand over to Dr. Tanya Steed, who will introduce herself, but also talk us through, as you can see here, the increasing use of digital technology in primary care, and specifically how this has impacted on Weymouth and Portland patients. So just a reminder to everyone to keep asking questions, making observations, comments in the chat as we're speaking. But Tanya, I'll hand over to you for your talk. Thank you.
Thanks very much, Mel. So good afternoon, everyone, and thank you for giving me the opportunity to speak today and take part in this Festival of Social Science event. So just to introduce myself, I'm Dr. Tanya Stead. I'm a GP by trade. I've been working in Weymouth and Portland at the Royal Crescent Surgery for the past 12 years. And I also work as the clinical director for Weymouth and Portland Primary Care Network, which is quite a mouthful. That's basically an organisation that represents the 6 practices in Weymouth and Portland. And today I want to talk about the increasing use of digital technology in primary care. How has this impacted on our patients in Weymouth and Portland, and really start to address the issues and the concerns that we have that those that are not digitally enabled are being left behind. Next slide, please. So I just wanted to very briefly just talk about what the situation is like for primary care in Weymouth and Portland now, and what are some of the changes that we've seen, and why digital is seen as something that is very beneficial for primary care. So in the last few years, we've noticed a real change in our workload. It's been going up and up and up. We've got an aging population. Many patients retire in Weymouth and Portland, and like many GPs across the UK, we've seen increasing medical complexity. Our patients have more complex comorbidities, are on more medications. And as medicine becomes more complex, what we find is often there's a shift of what work was traditionally done in secondary care being pushed into primary care as well. A few years ago, the NHS was very keen for practices to start to work collaboratively together. And in 2019, the Weymouth and Portland Primary Care Network was formed. So this is a body that comprises the 6 GP practices of Weymouth and Portland. And GPs are paid for work that they do as a network, as well as for work they do as individual practices. And along with the development of the PCN, our federation, which is an organisation that employs our primary care network staff and helps run its services, has also developed, and it's called Two Harbours Healthcare. We've seen quite a significant change in our workforce. We've seen more and more GPs wanting to become salaried rather than be partners. We've seen more advanced nurse practitioners taking a greater role in primary care and doing jobs that GPs traditionally did. And primary care networks have been given more staff through the network funds to employ additional roles. So staff like paramedics, physicians associates, a whole ream of roles to try and support primary care. The way that we work's changed. We have different delivery models. So in Weymouth and Portland, we have what's called the Weymouth Elderly Care Service. So our frail patients have a team that support them. That's the housebound and those in care homes. If you need a visit and you're frail, you might not be visited by your GP, but the MUX service, which is our mobile urgent care service. So there's all sorts of different services that are there that weren't. And not only do GPs try and do work and manage acute medical problems and long-term conditions, we're also starting to do more population health management work as part of our network. And in Dorset, we're really lucky to have a fantastic digital tool, which is affectionately called the DICE tool. And that's the Dorset Intelligence and Insight Service. And it's an amazing digital tool that links data from health and social care from all of Dorset's services, brings them together, and you can really use that to kind of plan and help develop your services, and look to see who really needs your help, and look at health inequalities. And so increasingly over the years, digital technologies have been pushed and encouraged in the NHS for managing patients' long-term conditions, like my COPD app, for doing tests at home. So ACR is a test where urine is dipped to look to see if the kidneys are leaking protein. And there was a project that our PCN was involved in last year where test kits were sent to patients' homes, and the results could then be uploaded onto a patient's phone and sent directly to us. And then remote monitoring, like monitoring patients' blood pressure. Next slide, please. So increasingly, digital was being added and has been used by primary care, and then COVID came, and that had a profound impact on how we use digital in primary care. Pretty much overnight, we had to move to complete telephone triage. We had to create hot and cold sites. So if a patient presented with a temperature and we weren't sure they had COVID, they needed to be seen in a hot site. And we needed to have dedicated cold sites where patients who were vulnerable and needed to be seen and assessed could be seen safely. E-consultation is a service where patients contact us online, filling out an online form, and we respond in 48 hours, was heavily promoted. It was available before COVID, but very much was pushed after. And in some areas, particularly Bridport, they went to a service where you could only access primary care if you did an e-consult. Text messaging has become much more widely used, and I think we'll never go back from that. We use that very widely at the moment, particularly using a system called AccuRx at the moment, locally in my practice. Video consultation was quite popular initially, but I have to say is used less and less. GPs found it quite cumbersome. It takes time for patients to log on, but it has been widely used by secondary care and is still quite often used by our WEX service when they interact with care homes. Teledermatology is more and more widely used. That's where patients have skin problems and patients are asked to take photographs of their skin complaints. And then also if patients are seen by GPs and we're not sure quite what to do, we want a bit more advice, because dermatology is quite difficult to access at the moment, we can send pictures to consultants and get their advice and manage it locally at practice level. Without a doubt, COVID had a massive impact on our long-term condition management. With the first lockdown, we ended up 3 months behind with our, say, diabetic reviews. And that was made worse more recently when there was a blood bottle shortage nationally. And I would say we're about 4 months behind on our diabetic reviews locally in my practice. And I'm sure that's the case in other GP surgeries. We've also had to change the way we do long-term condition management. If patients have got no problems with their diabetes and actually their blood pressure is well controlled, we actually now send them a report and information rather than arranging an actual face-to-face appointment. Prescriptions are predominantly sent electronically, so very few paper prescriptions are done now. It's all done online. Letters, reports, sick notes are usually sent via email or text. And COVID vaccination clinics had a massive impact on our GP services. A huge amount of our time, our business manager, practice manager, admin time and clinician time was taking up creating, setting up and running the vaccination services locally. And new services needed to be created. For example, the pulse oximetry service. So that's a service where we monitor patients' oxygen levels if they've got COVID, so that if they fall, we can ensure that they get to hospital safely and urgent and quickly. Next slide, please. So what was the impact on patients? There was a definite impact on access for patients. With everyone going to telephone triage, it was very difficult to get through on the phone. And coinciding with that, there was this national push to get patients to access places like minor injury units, the urgent treatment centre and the emergency department via 111 rather than coming to the centres directly. And I and lots of GPs locally were really concerned about patients bouncing between services, not getting to who they needed to see. Patients had to adapt to different consultation methods using the telephone or video consults. And there was definite increased waits for secondary care, and this is going to be a problem moving forward. It's not going to go away. Patients are waiting increasingly longer times for outpatient appointments and surgery. Clearly, as I've mentioned before, delays and changes to how long-term condition care is managed, and increasing use of texts and emails to communicate with patients. And that brings up all sorts of problems. Most recently, we had a few scam texts going to patients pretending to be from our vaccination centre. And increasingly, patients are being offered digital apps and remote monitoring services. Next slide, please. So how is the PCN reaching those who are digitally excluded? So the first important thing was how much of this is a problem. And locally in Weymouth and Portland, we're really, really lucky. Our patient participation groups, our PPGs, are really strong, and each surgery has a PPG. And the chair of chairs of all the PPGs is Peter Greensmith, who's going to speak later. And he sits on our PCN board, and he kept coming up and saying, look, what's happening here? What's happening to our patients who can't use all these digital services? Are they being excluded? And the PPG decided to undertake a survey called the Weymouth and Portland Patient Experience Survey. And the PCN very much tried to work with the PPG collaboratively to ensure that our patients did complete the surveys and that the surveys were distributed. And I have to say the survey's been brilliant, really good uptake and really interesting findings. And I won't go into it in too much detail because Peter's going to follow me and discuss that in a bit more detail. Following the results of the survey, a Weymouth and Portland working group was created with members of the PPG and GP practices, GP practice staff coming together and looking at particular areas: access, technology, communication and suggestions. And they came up with a fantastic document with lots of ideas of ways in which they felt we could try and support our patients and try and prevent digital exclusion. And they met quite regularly, and then they've taken those ideas to individual PPGs and will continue to work with individual practices. And the survey had quite an impact on, I think, the PCN network leaders, the GP leaders and our practice managers. Clearly, as we got a better understanding of COVID, practices started to really get concerned that we needed to be seeing some of our patients face to face without them being offered an initial telephone triage. And that was an important thing that we felt we should do collectively, and we've shared ideas of who should be invited directly to ensure that we've got a consistent offer across the network. Next slide, please. Moving forward, one of the really key things that we felt was so important and fundamental was that we've got to ask patients, how do they want to be contacted? And that we have to create systems so that that is recorded regularly and accurately, and is not just left to an ad hoc method, you know, where patients are just asked occasionally. So accurate, up-to-date recording of patients' preferred method of contact is key, and all the practices are doing work on trying to do that. Changing attitudes. So I think there's been a lot of attitude change in the senior leadership level, and it's so important when we're planning services or using digital technology or discussing a new digital technology service that we ensure that there's adequate resource and alternative pathways in place to kind of meet the needs of those that are not digitally enabled. And it's really interesting. I go to a meeting with Dorset County Hospital to pick up problems that arise between primary and secondary care. And they had a great idea. They were going to set up some kind of resource where patients could get information about what to do whilst they're on a waiting list to keep healthy, with some signposting to mental health services for patients that have got to wait, you know, in pain, say for a hip operation. And they wanted to do it online and have an online site. And I remember saying, well, what about those patients that can't use online? And they're going, and the realization they're going, oh yeah, we need to make sure we've got paper copies and that patients get the opportunity to be offered that. personalised care. So whatever you do, some patients are going to need a more personalised approach. And one of the additional roles that we have is care coordinators. And we would like to use our care coordinators to help those patients that struggle to navigate service pathways. And those care coordinators really need to go to where patients are. So, for example, we're going to get them to go to the leg club. We've got a leg club that meets, and go and ask patients what are some of the problems they're facing. It's important that we look at resources and education for those that want to learn. And that's not just educating our patients, it's educating our staff who are going to educate our patients. And that's something we really need to spend some time and resource into. It's so important to support our vulnerable groups, and Weymouth and Portland have done a lot of work to support our homeless population and have been working collaboratively with the Lantern, the homeless charity in Weymouth. And have done a lot to try and improve our offer to the learning disability patients that we have. A most recent example of something we're trying to do is Heidi Crompton is our advanced nurse practitioner who leads on homeless, and something she'd like to do is create a homeless charter. A buzzword at the moment is called reasonable adjustments, and she would like to create sort of some adjustments or a charter that all GPs will sign up to locally. For example, a lot of homeless people don't have very expensive phones. They lose them very often. They frequently have new telephone numbers, and the numbers we have for them aren't up to date. And one thing they often want is a sick note or need a sick note. And traditionally, we often text it out to patients, and the text has a link to their sick note. Well, that's not terribly helpful if you're homeless, you don't have a printer, and you don't have a smartphone. So it's things like that that we need to constantly think about and get engaged with. We need to continue to listen and collaborate with our PPGs and come up with local solutions and be proactive with that. And we will continue to do population health management work. And every few months, the PCN get PLT, sorry about all the abbreviations, that's a protected learning time where GPs can sit together and do some work together. And we'd like to look at health inequalities and try and identify new health inequalities. And I'm sure digital will be something that we talk about. Next slide, please. Oh, sorry, there was a questions. So just to sum up, really, what I probably would say is that primary care is facing unprecedented demand. And without a doubt, digital is really, really, really useful for some patients and will be needed for us to manage our patients and to support our patients in their health needs. But it's not for all. And what we need to do is make sure that we always have resource and redivert resource to those patients that aren't digitally enabled. I hope that's been helpful, and I'm happy to answer any questions if anyone has anything they'd like to ask.
Tanya, thank you so much for taking the time, and actually it's incredibly useful for you to kind of outline some of the challenges and the impacts on GPs and how service is delivered, as well as then thinking about the impact on people that are at risk of being digitally excluded. I know that there's been a number of questions in the chat. We've got about 5 minutes. Stevie, did you want to just sort of pull out maybe a couple of the questions for the chat for Tanya to respond to? We might not be able to get through all of them, but we have got 5 minutes before we move on to the next presentation.
Yep, no worries. Just having a look. Thanks to everyone who introduced themselves. Peter had a question for Tanya. Oh, he's put some questions in there. What are the Dorset CCG doing to address issues with regards to PPGs that are not working so well? And how many PPGs are currently active in Dorset County?
Ooh,
hard questions.
Yeah, I might not know answers to PPGs outside my area. Certainly clinical directors do talk together about issues, but I wouldn't necessarily know which areas had PPGs that weren't being supported enough or didn't have enough support. But I can certainly find out. I know that Jim from the CCG is there to support PPG development. Is that right? I don't know if Jim's on the call.
Yeah, hi Tanya, I'm here, and yeah, to answer the question, it's a very good question. I don't have the actual numbers and everything to hand. But one of the things to say about Dorset is that they're really committed to helping and supporting PPGs. In Dorset ourselves, the CCG has employed myself and my colleague Jill, and we're both full-time and we're both dedicated to helping and supporting PPGs throughout Dorset. And it's one of the things we're trying to do. And the whole project with Weymouth and Portland, I think, is partly kind of the evidence of what has been happening when you've got an active and a proactive PPG, and other health bodies like general practice and CCGs and things like that, all working together to try and come up with problems. To try and come up with solutions to problems together. And it's one of the things we're working on there. And there's a number of different projects that myself and my colleague Jill are working at with lots of different PPGs throughout Dorset. I can get the exact figures and report back to Bournemouth University so they can publish that. But again, I don't have those figures to hand.
Okay. Someone has just asked if the slides will be shared. I just wanted to say that yes, they will. I'm going to email them out and I'll also make them available online. Okay. Someone has asked, how will the changes RE-ICS improve health outcomes?
Oh, that's a massive question. I mean, as GPs, we have had concerns that primary care won't be adequately represented within the ICS. And
sorry, Tanya, would you mind just explaining to everybody what ICS is? Just because the range of people here is that
sure,
you might know.
Okay, so what is called the Dorset CCG will be coming to an end, and we'll have an integrated care service system, we are currently there's currently work going into forming how the ICS will look and what structures there are, basically there have been, so I'm going to speak very much from my private primary care perspective. There have been some concerns that primary care might not be adequately represented within the ICS, and work has been going on in developing it. I'm afraid there could be I can give people information about the ICS, but that's a whole hour to chat about, because there's lots of bits to it and how areas are going to be represented. Going back to the original question about will the change to ICS ensure that we address this concern about digital exclusion, I would say we need to be very careful, because I think every solution that comes through the NHS is always going to be pushed as a digital solution first, because it's wide-ranging and it's financially a good offer, and for often the majority of patients it's a good system. And I think there's always got to be push if we get concerns and worries that patients are starting to be excluded. What I would say is that we've got good evidence if services are being pushed forward to push back, and with tools like the DICE tool, and the big agenda at the moment is health inequalities, and there's money being put forward for health inequalities. These topics are being raised again and again, and I think there is system change and attitude change now towards an understanding that digital isn't always the solution for everyone.
Tanya, I'm going to move us on, but a huge thank you for you sharing that presentation and for starting to answer some of the questions that are starting to come through. If I could just say to everyone, please do hold on to those questions and keep posting questions and comments into the chat. We'll be able to take a lot of those into the small group work that we're going to be doing after the presentations. But also, if I can encourage the presenters, but also other people that are online with us today, to feel able to just respond to some of those questions in the chat as well, so we have those conversations going as we go along. Stevie, are you happy to move on to the next slide, and I will just introduce a little bit about the work that we've been doing with National Voices, just to set the scene a little bit about what some of the issues were that we found, and particularly some of those local conversations and insights that we had with the narratives that we created. So next slide, please. So just to show you this report again, and as I said, we'll send out a link. In fact, I'll put a link in the chat in a minute. But this main kind of report that National Voices included has lots of case studies, lots of solutions, lots of best case examples of how people around the country have started to address a lot of these needs that we've already started to identify in the presentation so far, and some of the questions in the chat. Next slide, please, Stevie. In terms of the report overall, so it was a literature review. It looked at a lot of discussions with all the different organisations that were part of National Voices, and also they used the narrative insights that we created and another organisation that's based in London created, to come up with some key findings around this very issue, around everything kind of going to digital kind of delivery, so both phone and internet access. Actually, what we found is that people understand the reason for and potential benefits of remote care. So this isn't particularly about kind of PR. This isn't about trying to promote all of the benefits. Actually, what was found sort of across the national report is that people understood the reasons for it. But the reality is that many people really struggled to access services during COVID throughout generally. But then specifically in terms of the triage by phone and online, not just in primary care services like GP, but also right across the NHS, but also in social care and community organisations as well. Actually, what we found is that people were digitally excluded for a whole range of different reasons. So actually we need to think about those different reasons when we're identifying solutions, because there is no one size that fits all. So people presented with a whole range of reasons, but also a range of different support needs. So it isn't as simple as providing training for people to be able to use technology. It was much more nuanced than that, and we'll share some of those in this presentation. The key kind of finding from the national report was that actually poorly executed remote care negatively impacts on people's experience and quality of care. And actually a number of reports have come out since, and there was one just this week from the University of Cambridge that found that whilst it had really benefited, online access had really benefited some people, there was a real concern about the quality of diagnosis and treatment, and they went as far as to say that for some people actually that had been disastrous. That was the word that they used. So it's something that we need to think about when we have our discussions today and in our practice about how we kind of address those multiple reasons. Next slide, please, Stevie. So these were the main kind of recommendations that came out of the National Voices work that we contributed to. And I think they really fit actually with some of the ideas that Dr. Tanya Stead was identifying in terms of what Weymouth and Portland are trying to do locally. So inclusion being the core principle was a key recommendation. So making sure that people have the same quality of care and access to treatment and support regardless of how they access it. Co-designing with people, so whatever new way of working or particular way of working happens, that's co-produced, that's done in consultation with people, but again particularly thinking about who we're consulting with and making sure that that includes the people that are most excluded. Offering supported choice and personalisation, so actually having that flexibility to have different ways of engaging was really important. Supporting staff to innovate, and this is very much what today is about, but actually we know that lots of you that are here that are working on the front line in the community or in the health service, actually you've got some fantastic ideas and understanding about how to do this. Lots of you are doing it anyway, and this is an opportunity to bring that together, share that innovative practice, and also kind of garner support for that so you can do it more. And then the wider one, I mentioned that in the report there are lots of case studies and lots of examples of best practice. And what was interesting about those is they were all very different, and they were often working with and targeting different excluded communities. But actually the kind of the shared theme is that they recognise that health is wider than healthcare. So many of those very successful projects and activities were ones that came out of health settings, out of kind of local authority settings, and really engaged with the community and looked at broader kind of support that included access to treatment and support. Next slide, please, Stevie. In terms of our local work and the interviews we did around the personal insights, we expected to find that digital poverty was an issue. So we expected to find people that had limited access to the internet or limited skills or confidence in using online resources. Actually, we found a lot of other reasons as well that we weren't necessarily expecting. So a huge theme that we found locally was around dependence and independence. People saying to us that having to go access services through phone triage or through the internet meant that they now had to be dependent on another person to help them do it for a whole host of reasons. And that was a real issue for people that are normally very independent and able to manage their own healthcare. Privacy was another issue that came up around people waiting for that phone call back, and when they got it, they were in a public space, they were in the workplace, they were on a bus. In one case, they were at the bottom of the garden because that was the only place they could get a signal on their phone. So privacy of having those conversations was a huge issue. And finally, a big theme locally for us in the insight work was around feeling valued and included, or rather not feeling valued. So people felt that this whole shift to a online delivery, which did not work for them, really devalued and dismissed who they were and that they were important. So that was something that we really need to address. So Steve, I'm going to hand over to you to share some of the insights from those narratives and some of the quotes from people within the work that you did.
Thanks, Mel. Just share my video. Okay. Okay, so Mel has sort of discussed the work we've been doing with National Voices, and both Mel and Tanya have sort of discussed some of the issues that have come from this move towards digital methods of accessing healthcare. But I thought I would just take you a little bit deeper into the part of the project that I was involved in, and what I found out. On this slide, there's just a bit of information about sort of why and how I carried out the piece of research that I was involved in. So I carried out 11 really in-depth interviews with some really varied and incredible group of people with a huge variety of life experiences. This included those of all different ages, people with experience as diabetes and cancer patients, people with experience with addiction and homelessness. So I really wanted to make sure we had a really wide range of people that I was speaking to. So I listened to their stories and their experiences with accessing healthcare, both sort of pre-COVID and post-COVID, to see sort of a comparison there. Okay. Yeah, so before going into this project, I sort of had an idea of what I thought I was going to see, what I was expecting, and what factors might be at play. But what I found out was just so much bigger than I imagined. I would sort of think of perhaps the older members of my family who hadn't quite figured out, you know, that they didn't need to put their phone to their ear when they were on FaceTime, that sort of thing. But it's so much deeper than that. And I mean, age is a factor. If you look at some of the quotes on the screen right now from a few of the older participants that I spoke to, some of them feel that technology is just too much for them, that they have simply filled their brains with so much stuff over their lifetime, over their 70, 80, 90 years. And they don't feel like they want to spend the rest of their time trying to cram something in and learn that huge new skill. So the participants from which the second and third quotes were taken on the screen, they really discussed with me this feeling that they are being left behind, that nobody cares if they're missing out, and that they honestly feel that people just can't wait for them to get rid of them, honestly, and so they don't have to worry about that anymore, which I felt was really sad to hear. And as Mel's discussed earlier, that another theme that came up was sort of around that independence, that privacy issue. So there's a quote on the screen from Angela, and Angela was had been profoundly deaf since she was young. So actually she had experience of people making assumptions, because she's now getting older, she's in her 60s. She had people making assumptions that the struggle she was having was due to her age, but actually she'd been having issues with access due to her hearing loss since she was younger. So she knows that that's not just an issue for older people. But Angela says she feels that her medical interactions should be something that she is able to keep private despite her issues with hearing loss, and that she should be able to deal with them in private. But she says that in her house, she only has one phone with the specific loop system that she needs to be able to hear her doctor. But that her doctor's surgery insists on having a mobile as their main method of contacting her. So this means that she needs, if they're contacting on her mobile, she doesn't have the loop system. She needs her husband or somebody there to help her and sort of go back and forth between them. And she can't go away and have a private discussion. And she finds this really upsetting because it's that loss of privacy and independence. And the quote at the bottom of the screen came from Paul. Paul, who he had type 2 diabetes. He's had that for 18 years. He's also visually impaired. He has an ongoing melanoma in his eye. And he's also been a carer for his father, who had liver and lung cancer. So with all of these medical needs and responsibilities, Paul has really struggled with this move to digital methods. Again, he can't really access digital forms or anything like that by himself because of his vision loss. So again, he has to have his wife help him. He can't manage that by himself. If he has something there on paper, he can use something like a magnifying glass or something to enlarge it, but he really struggles with digital. So that's a struggle for him. Okay, so I'm just going to quickly run through a few more themes that came up in the study. So I did meet some people who were experiencing digital poverty. Not all of them could afford computers or all the other gadgets that are out there these days. Some of them were still only had a landline in their house. They were unable to take pictures, send pictures or emails or any of those things. And not only that, but there were so many other physical circumstances that prevented people from being able to seek the medical help that they needed, such as living in more remote areas, having a lack of signal. Some of them would have to sort of walk quite far to get the signal that they would need. Many people who were simply not brought up with technology, some were sort of discussing how they had actually really tried to learn. They had attended computer courses. They had tried to find out, how to access, but they still struggle. They still struggle to turn on a device, to log in to certain websites, even find websites that they need to find. It's just not something that they can manage to learn. And I think it's often assumed that those who need it, such as those older people, those people with a disability, or those people that struggle to access these methods, will have someone to support them. That they will have someone there, a child or a partner or a neighbour. But that really isn't the truth. I spoke to one lady who had, she'd never had children. She was divorced. She just didn't feel that she had anyone that she could bother to show her how to access the things that she needed to access. And in any case, as we previously discussed, those who are forced to rely on other people will begin to lose that sense of privacy and independence, where they should be given every opportunity to keep it. Similarly, I had a few participants from the deaf and the blind communities, and they discussed how they already felt that their needs, it was very difficult for their needs to be met. They weren't being catered for pre-pandemic. They already struggled to have that independence, and now there's just another layer to contend with. And my last point at the bottom of this page brings me on to my last story that I'm going to share with you. It's a story about someone called Simon who describes himself as an addict, and he is someone who has really turned his life around and has been in recovery since April 2020. So I'm just going to share that with you. So Simon was previously homeless. He was extremely isolated from society by his drug use, until he, fortunately he was able to go into the care of a charity who secured him some accommodation. And since then, he's just realized how many challenges he faces to be able to become part of mainstream society again. He's had to learn all of these skills, and technology is just another layer to that again, that he's got to contend with and learn about. He says that technology really unsettles him and that he really struggles to do it, that it hurts his head. And he also says that when he was sort of beginning his experience with recovery, he would have one-to-ones with his doctor really, really frequently. And he says that this was absolutely life-changing for him, that he honestly believes he wouldn't have survived without those one-to-ones with his doctor. So I think he worries both for himself and for other people that they won't have access to those, personal, conversations in a room, private, with your doctor. And there's an example there as well of, before he fell into his addiction, the digital world was nowhere near where it is now. So we were still writing our CVs. You could still write CVs, but now it's all online applications and stuff like that. And he just really struggled, and he said that he has got to the point where he's just cried because he doesn't know how to do it and what to do. And he just feels that there should be a way for people to do these things if they just can't quite get their head around the online world. And this was a quote from him, that he felt like he'd come out of prison, which he hadn't been in prison, but he just felt like he'd come out into this world that he just didn't understand, that he just wasn't a part of, which was just really sad. And that point, I think it's at the bottom there. So a lot of people actually brought up this point of not wanting to be dependent on technology. I think he had sort of a laptop that was on loan from the charity, and it was only, I think he could have it for a year or something, and he had so much fear that that would be taken away and he wouldn't be able to source another method. And I think a lot of people felt that way, that they were so on the breadline that at any point they might not be able to afford these things, to pay for Wi-Fi or whatever those things are. So to become dependent on them was a scary thought. So yeah, that was my story about Simon, and I think that's me done. Over to Peter.
Perfectly on time there. Thank you ever so much, Stevie. And just to kind of sum up a little bit, so the work that we did was kind of qualitative. So it wasn't about trying to be representative. It was about kind of having illustrations. And I think everything you covered there, Stevie, perfectly illustrated some of the different experiences people have. And as some of the people have been putting in the chat, it's not just about older people. It is kind of lots of issues for different people around engaging, and we need to be coming up with solutions that respond to all of those. There's been some fantastic comments in the chat, and thank you so much for people making suggestions and responding to other people's questions, because that's exactly what we wanted today to be about. And as I said, the second half of today's sessions is going to be in group work, where everybody will have a chance to really talk through some of these issues, about kind of what struck you about some of the presentations, what you're doing within your own practice, and sharing some of that, so we've got some clear action points from today. So our final presenter, before we move on into those groups, we'll have a break after the next presentation and then move into the group work. But the next presentation is Peter, Chair of Weymouth and Portland Patient Participation Group, who's going to be talking about the survey that Dr. Tony Stead referred to, and really kind of illustrating what the local picture is in Weymouth, Portland, in terms of internet access and people's views around engaging online and by phone. So Peter, over to you.
Thank you, Mel, and good afternoon. As Mel says, I'm going to cover the Weymouth and Portland patient experience survey findings. what we've been doing to follow up those findings, because a lot of patients say, well, what's been done with the surveys that we've completed? And also I'll put it into a little bit of a national context. We've heard some, but I've added my own. Now, as Tanya said, we have 6 GP practices. Each of our practices has a patient participation group. We discuss patient issues, and I take those to the primary care network, where with other issues, they are looked at. So you have Dorset County Hospital there, Dorset Healthcare, etc. So it's a two-way process, and then the answers to those come back out and they go back into the groups. We are volunteers, and that needs to be understood by everybody, but we also do care for our local NHS. Next slide, please. As many will know, Weymouth and Portland as a locality has multiple deprivation. Not a boast, but sadly we have the busiest food bank in Dorset. However, I've only been here 9 years, but it has a lot of good things down here in Weymouth and Portland, particularly the natural surroundings, the sea, the seafood. And I think it's a great opportunity for employers who can and are willing to move into an area such as this, because there is a large workforce. If they were paid the national wage, you're going to get a good result, I believe, but enough of the politics. That was just a little dig to support Weymouth and Portland. Next slide, please. Now, we all know that COVID had a massive impact on the NHS, this rapid move to digital first, and many services were paused. It had a massive impact on patients. Fewer face-to-face consultations was one of those. So we wanted to find out what was the impact, to try and quantify the impact on patients over here. And we got agreement from the primary care network, and we got funding from the commissioning group to run a survey based on Picker Institute principles. And it was run by a company which the CCG employed. Next slide, please. What we found helps quantify the size of the problem. We found that 24% of our population here are not connected or do not use the internet. We found that 35% of those with a disability are not connected. 50% of those over 70 years old are also not connected. Now, when we looked in, because they gave us quantifiable information as to why they weren't connected, 70% of them are not interested in the internet. They don't have the skills, they don't have the confidence. 24% of them don't have the equipment, and they cannot afford to buy and use it. So we have been able to quantify the size of it. And as someone in the chat room said, it's not just the elderly, this goes across all age groups. Next slide, please. We also found that 24% of the population here cannot explain symptoms over the phone, and they're not confident talking to their GP by phone. So the start of my business career, I was in research for a couple of years, and at the end of my career, I was in the NHS for 8 years. So I went back to have a look at some of the sources I was using over time: Nuffield Trust, Dorset Health Watch, National Voices. Next slide, please. I also looked at some Dorset information. This is from Wessex Academic Health Social Network, which was funded by the CCG. 39 doctors took part. And the medics were saying, and this came out a number of months ago, it isn't working well for all. Sorry, for a minority, it does actually work quite well, but for the majority of patients, one size does not fit all. What the medics are saying, it's missing body language, missing context, and they feel, or some of them feel, that they've been led by the technology. Next slide, please. I also was listening to Dr. Tim Ferris, who's the Director of NHS Transformation, and he pointed out, so I have noted, and I think it's something that we need to bear in mind, that as NHS transformation, they wish to reduce health inequalities. So at the time we're introducing digital, we need to be looking to reduce health inequalities. Next slide, please. But if we return to the Weymouth and Portland survey and communications, the data has enabled us to show that if we take the main age groups, which are those on the right in the pie chart, so the 3 main age groups, and we also look at the media that they use to find out about health, and this is broken down by practice, so the data goes down by practice, we can actually work out how the health services and care services can communicate best to those relevant groups. We often hear, when we put it on the website, only 13% of us over here, and you'll find this is pretty similar nationally, use our health website. It's very low. Only 9% of us use social media for health information. Yet I often hear, we've gone out on social media. So my question really for the commissioners and for providers is, please start to look at multimedia campaigns if you want to communicate to the different patient groups. Next slide, please. Websites. 40% of us visit a website, a health website. 38% of us don't ever. If you look at other bits of research by McKinsey and others, they will say the actual number of times per annum we go is very low. It's once or twice a year. It's not like using a grocery website or Amazon. The population do not go to health websites often for health information. I don't know why, and it's particularly the younger age groups are quite skeptical about some of them as well, even the NHS ones. Next slide, please. Our PPGs formed a working group with our 2 practice managers that joined us, and we looked at access, communications and technology. Those were the 3 major themes that we wanted to focus on. Next slide, please. I don't think it'll surprise you, but the biggest patient issue is face-to-face consultations, which fell to 50% from 80%. But in addition, remember, over 20% of us are not confident in using the phone to describe symptoms to GPs. Getting through to receptionists, times on the phone has increased. Patients are obviously asking for more face-to-face consultations. And it's not just patients, it's GPs and consultants that do have concerns over telephone consultations and video consultations. Next slide, please. The COVID, and in the survey, it confirmed to us that communication has become a bigger issue, and there's a bigger need to get this right between patients, the public and health service. And we've also found this at a national level, as Mel and Stevie were saying earlier. Next slide, please. So going back to this slide on data, you do need to look at multimedia approaches to the population, to, as the medics would say, if like different cohorts, or as we would say, different segments of the population by age. Social media, for example, is very low, and telephone usage and problems with the telephone goes across all age groups as well. So it's not just the elderly that have this problem. Next slide, please. And I'll read from this one because I think it's a very important thing to note, that from National Voices, they're saying no matter how people choose to interact with services, they should receive the same levels of access, consistent advice and outcomes of care, regardless of the channel. One size certainly does not fit all. Next slide, please. Their recommendation is to give patients information that is relevant, clear, accurate, evidence-based and is up to date. And we would certainly support that and endorse it. Next, before we go to the next slide, go back one, please, Stevie, sorry. Like Mel, I only got yesterday, actually, I don't know if she may have had received it before me, This report from Cambridge, study from Cambridge University with 1,340 patients, 111 clinicians. I'll just read you two of the lines that came out in the summary. 86% of patients and 93% of clinicians thought remote consultations were worse than face-to-face for accuracy of assessments. The rapid digitalization and use of telemedicine must stay, but appropriate patient selection is key. It is perfect for some, but disastrous for others. So is this about convenience, or is this about accuracy and diagnosis? Next slide, please. In terms of technology, quite a lot came out in terms of in the survey on technology. I've just put this up one, and if you look at the bottom in the bar, in the what's the Patients Association, if I can take you down to the bottom, they're all colleges and many medical charities are saying, currently it's not enough is being done to ensure that patients are included in involving policy discussions surrounding the development, implementation, or evaluation of digital health technologies. There is limited understanding of what patients actually want from digital health. Next slide, please. I've looked at Nuffield Trust and NHS providers, if the providers of services are here, and also national voices. And then the themes that are coming out here are, first of all, it is essential that you co-design with your end user. And that is both in terms of Nuffield Trust, that is also NHS providers of services. They're saying it's not just the staff usage, it's the service users and patient users. And National Voice is saying this is about inclusion. So we must look to see if these systems are inclusive, or are they excluding many, many people. Next slide, please. I looked at our Dorset website, and I'll take you to the bottom, the emboldened copy at the bottom. There's a statement here which is on the website, and it's also on DCH, Dorset County Hospital, and it's in some of the consultant letters that come out to you asking you to attend a telephone or a video consultation. By offering a digital first approach to appointments, we can support you in saving time and money associated with travel, enable you to access care and more quickly, which is of course correct. But if you go back to the Cambridge study, which I'm not going to go back to, is this about convenience? And for some, yes, or is it about accuracy? So, you know, that is a big dimension that we actually need to think about. Next slide, please. And this I found in the British Medical Journal. They also found that many doctors are saying, yes, it works fine for the healthy and business people who, but it doesn't work for many. And in fact, it's a large segment that have problems with it. Next slide, please. So what recommendations are coming out from people like Nuffield Trust? They say there's a risk of creating health inequalities through digital healthcare. I think it's here. I think there's enough evidence now nationally and locally to say that we need to look at it because it is creating inequalities. Secondly, we also know, and Tanya and I've listened to other doctors have said this, it's increasing their workload. And thirdly, for some patients, they're having to make 2 or 3 telephone calls to actually get a diagnosis and to get some treatment. So it's adding to the workload as well. Next slide, please. They suggest 4 principles: consult and co-design with patients and service users, not just staff. Test the system, learn from that, integrate and adapt, but message carefully. It's not just the message, it's also the media that is to be used if you want to get your messages out there. Next slide, please. This is from Plymouth University Hospital. So this is an acute hospital, a survey that they did, both from their clinicians and their patients for telephone and video consultees. The quality of communication in non-face-to-face consultations is lower than in face-to-face consultations. If I move on to the next slide, please, is my summary slide. I think without doubt we were able to quantify the size of the possible or the actual digital exclusion in Weymouth and Portland, at least 24% of our population. Now, digital first excludes not only those that we may think is the older population, but it goes right down the age profile, and particularly for people with disabilities. Obviously, digital has benefits for a number of us, but it also has drawbacks for patients, and it does for the doctors and the clinicians as well. NHS transformation aims to reduce health and care inequalities, so that's something that we need to put in when we're looking at the systems that are being offered. Will it reduce inequalities? How can we reduce them? Inclusive systems are needed. To do that, you need to co-design with the patients and the service users as well. And information, let's give information that is accurate, that is evidence-based, and that is actually up to date. People lose credibility if you give something that's slanted to suit your own message, which is not what the public or patients are feeling. NHS needs to be NHS information needs to use a multimedia approach to obtain coverage. Our final point is, how can we pull all of this together to ensure that the health and care systems are more inclusive? So thank you all for listening, and if there's any time left, Mel, I'll take questions. Thank you.
Yeah.